You have to think, okay, I want to look for skin lesions, look for it. I want to look for fistula, look for it. You have to do that. Otherwise, this fistula is not easy to see. Unless you think about it, okay, I'm looking at a fistula, and fistula is usually between two disease segments. You won't get a fistula from this disease to a normal place. It won't happen. It has to be a disease segment to a disease segment, right? Okay. So next, how will the diagnosis be made?
So she made a biopsy from biopsy.
How do you get a biopsy?
From colonoscopy.
Yeah, okay. It's patient will
Colonoscopy,
benefit from a colonoscopy and a biopsy. So that would be your last sentence, okay?
Okay. Yeah.
Okay, next.
Okay, hi Dato. Raja Azmi from UIA. So I would like to try. This is a chest abdominal radiograph in a neonatal patient. The the most striking here is the malposition of the UVC, in which it's located within the portal vein. I would expect the UVC tip will be in the inferior vena cava. The UAC tip is also, I think, malposition, in which in this image is located at the level of T12. So I would expect the high position would be on T6 until T9, or in low position would be on L3 until L5. Okay, apart from that, the gastric tube is in situ. The bowel is appears dilated with loss of its polygonal shape. I cannot appreciate any regular sign to suggest pneumoperitoneum. However, I think there is some area of aeropotiasin. Otherwise, I think that's all. The visualized lung fields appears are remarkable. So as conclusion, this is this image represent dilated small bowel with some aeropotia. So I'm thinking of necrotizing and enterocolitis. So I would like to know whether this baby is a prem or term baby. And
what do you think?
I think it's a prem baby because of the humeral head is not visualized.
Okay, so this is a prem, right? Okay, so your diagnosis is NEC with aeropotia. What is this?
The
that may be intramural air, okay? Doesn't look like free intraperitoneal air. Okay, intramural air. Okay, fine. So diagnosis is correct, okay? NEC with, you notice this aeropotia there, right at the periphery. Yes. So is the presence of aeropotia, does the presence of aeropotia change your management?
I think yes. So
How?
Because so it's indicate the urgency for the primary teams to maybe proceed with the operation.
So you think aeropotia is a surgical indication to do a laparotomy? Is that what you're saying?
Actually, I would like to revise my answer. So I think the most important findings is pneumoperitoneum instead of aeropotia.
Yes, okay. So air in the portal venous system is not an indication for laparotomy. It just tells you just the severity of the disease. That's all. Okay, indication for laparotomy is perforation. All right. Okay. Okay, you mentioned about the lines and tubes. Okay, let me tell you something for the exam. You may be shown a picture like this, but the lines and tubes are in normal position. So have a look at the lines and tubes and just mention whether they are in satisfactory position or not. Okay. If in satisfactory position, just say the lines and tubes are in satisfactory position and just finish off that sentence like that and then move on to the abnormality. Okay. Because you don't want to waste time talking about the lines and tubes when there's something else to talk about as well. All right. Like in this case, they are not normal. So of course, then you say, and you can actually just say the lines and tubes are not in satisfactory position. If the examiner wants to further ask you, so what's the normal good position and all that, then you want to elaborate, okay? Because the main test of this film is for the NEC, you see, not so much for the lines and tubes, all right? So to save time, if the lines and tubes are normal position, just say the lines and tubes are in satisfactory position. Otherwise, you say it's not in satisfactory position and then move on. If the examiner want to test you on that, if that's the purpose of this film, then they'll ask you further questions and say what is the normal position and things like that. Okay.
Okay. Thank you, Dato'.
Okay, next.
Hi, Dato'. This is Carmen from UN. Okay, this is an abdominal radiograph of an adult. I can see that there is gross dilatation of the large bowel, giving rise a coffee bean shape. Otherwise, trying to look for any pneumoperitoneum from this radiograph. I cannot appreciate any free air, extra luminary. There's also absent rectal gas. Otherwise, the bones are comfortable. I think this is a large bowel obstruction, likely due to a sigmoid volvulus. I would like to proceed with the CACT abdomen pelvis urgently and inform the findings to the surgical team.
Okay, so your diagnosis is sigmoid volvulus.
Yeah.
Did you say that? Okay. So
Yeah.
how did you describe the sigmoid volvulus? What did you say?
There's gross large bowel dilatation with the apex pointing to the left lower quadrant.
Apex is at the lower quadrant? Apex should be where?
The apex of the dilated bowel loop pointing to the right upper quadrant.
Yes.
With the abrupt cut off of the bowel gas pointing to the left side.
Okay. And then what else you say? Just think of the textbook. Say, what do they talk about sigmoid volvulus? What do they say?
Coffee bean appearance.
Why you don't say that? It's a nice coffee bean there staring at you.
I mentioned earlier.
You mentioned, is it?
Yeah.
Okay,
Sorry.
okay, then maybe I didn't hear you so clearly. Okay, so again, just think when you describe something, just think like you're on the phone talking to somebody from overseas and you tell them, I have a radiograph in front of me that shows a dilated loop of large bowel, which shows a coffee bean sign. Okay. Whoever is listening to the other end will tell you the diagnosis is a sigmoid volvulus. Am I right?
Yeah.
So that's what you must do in the exam. If there's a nice word to describe it, just describe it because it's so specific to that condition. That is why, right? Okay. What's the treatment for this?
I would inform the primary team, and then to proceed with a CECT
Right.
enrollment pelvis, and also to assess for the transition point at the sigma.
So
And usually the primary team will have the like decompression, rectal decompression.
yeah, yes, this patient needs a decompression. That's the first thing they will do. They won't go and do the CT and things like that. It's not necessary at the moment. The first thing they want to do is decompress, okay? Those days they put a flatus tube inside. Nowadays they just do an endoscopy. Through the endoscope, they will decompress. And when they do that, they can also see if there's any reason why this patient had a volvulus. Sometimes it can be secondary to things. Many a times it's not. It's just an elderly person with a redundant loop of bowel or something like that. Okay.
Okay.
So nowadays that's done. Then after that, if you want to do a CT or something, then you can. All right. So CT is not a standard thing that is done in a patient with sigmoid volvulus. All right. So now go back,
Okay.
go and read on all about sigmoid volvulus and cecal volvulus and how to differentiate the two. Okay.
All right. Thank you, Tato.
Okay. Next.
Good evening, Prof. I'm Pushpa from UIA.
Yeah.
Present to me is the chest radiograph in a frontal projection of a skeletally matured patient. There is a increase of ST seen at the left lung field. And also there is a the opacity is it's causing a mild tracheal deviation to the right, and there is also soft tissue opacity that obscuring the left scapula and otherwise there is no obvious rib erosions are noted at this region. On the right lung field, there is a few lung nodules noted at the right mid zone. Otherwise, the rest of the right lung fields appears clear. Heart is not enlarged and no pleural effusion on the right side. From this, the soft tissue at the with the obscuration of the left scapula, which could be aggressive bone lesion with soft tissue with lung metastasis.
So what possible tumor is that?
Sarcoma.
Yes. For flat bones, which what type of sarcoma?
Ewing sarcoma.
Yes, even possible, although the age is not correct, but that's a possibility to think about. Okay. All right. So next sentence.
I would like to proceed with a CT TAP for staging.
Okay.
And biopsy.
And
Biopsy NHP
normally
coordination.
bone tumors, what imaging would like to do?
MRI.
Yeah, of course. You do a CT to stage, a CT TAP, but you also do a MRI for the scapula because it identifies the lesion better, infiltration, because they may want to excise the whole thing, so they need to know. Okay. All right. So this is a test to check that whatever the abnormality you're seeing there is not intrathoracic but extrathoracic. And why do you say it's extrathoracic and not intrathoracic? Tell me.
Because if there's equal expansion of the lung, so it's
Yes.
not intrathoracic.
Okay, yes, the lung volume hasn't changed. Yes, what else?
There's no rib expansion or erosion.
Okay, fine. What else?
Mm,
Have you heard
yeah.
of the silhouette signs?
Yeah, yeah, Prof.
Yeah. So silhouette signs are extremely useful in chest X-rays. You know, many of you are not thought about that. See, you see the diaphragm so well. Okay,
Yeah.
you see the right heart border, the left heart border so well. You see the aorta and the mediastinum so well. You also see the hilum so well. Okay, everything is seen well. So it cannot be inside because if there's a mass there butting the diaphragm, you lose the diaphragm. That means there's no silhouette because that all these structures got air around it. All right. So that's a silhouette sign. It's a very useful sign to analyze chest radiograph. Nowadays, that skill is gone because the moment you see something, you will straight away do a CT and gives you the answer. All right. So things have changed nowadays. But a silhouette signs, if in the exam, if you're given a plain radiograph, it'd be very useful.
Yep.
Okay,
Hi,
Tom,
Dato.
next.
Hello, hi, Tong here from UM. This is a small bowel follow through in the frontal view. Um, I can see that there is opacification of the stomach and the small bowel, and the small bowel appears abnormal uh, with the valvulae conniventis appearing very close together, giving rise to a hidebound appearance. Um, Otherwise, I don't see any soft tissue calcifications. I don't see any abnormal bone lesion. The sacroiliac joints are preserved. I don't see any stricturing or any filling defects within the small bowel. Uh, Overall features may represent scleroderma, and I would like to correlate with the serological markers and also do a chest X-ray for further workup of scleroderma.
Okay, so this is fairly well demonstrated appearance of hidebound involving the small bowel. Okay, so this is scleroderma. You're right. Now the thing is, it just get flipped. Okay, never mind. Sorry, the image got flipped, but never mind. Okay, so on the radiograph, if you see a radiograph showing small bowel involvement by scleroderma, so you want to think of what are the other places that scleroderma can involve, like what?
The lungs, they can have interstitial lung disease. It can affect the esophagus. They can have esophageal dilatation. They also can have
So have a look, have a look, have a look. What do you see here? I know demonstrated well or not, but you see some contrast here.
oh, okay, that is the esophagus.
Yeah. So what does it mean?
Yeah, I think it's dilated. So this
Yeah.
further increases my confidence in the diagnosis of scleroderma.
Yes. And what other organs can get involved in scleroderma?
The lungs,
Yes. Can you see the lungs here?
yeah, there are reticular changes in the
Yes. Also here,
bilateral
the
lung.
reticular changes. Yeah. So there's honeycomb appearance there. So this is, see, there are other things that support your diagnosis. That's what you must do in the exam. This is full house for the whole thing. Okay.
Okay, okay. Thank you, Dato.
Now, how did this happen? Go back to this. Okay. Okay, diagnosis, somebody shout out.
Lazy fracture.
Elise, okay. It's not Montigia, right?
Oh,
Okay, I'll have a way to remember the G and the M. Okay, come next.
meaning, Prof, earlier from UIA, chest radiograph. This is chest radiograph implanted projection of an adult patient. There are lines overlying the bilateral hemothorax in giving the ECG list. So here, bilateral lung feels clear, no percolongation, no curly B lines. The trachea is centrally located. No hilar enlargement. The heart is enlarged with globular shape and it is symmetrical bilaterally. It also gives a heart water bottle appearance. Bilateral heart border is clearly visualized in giving Cribb's heart border sign. And otherwise, minimal fluoroefficient over the right cost of right there is a right minimal right fluoroefficiency. Left cost of an angle still preserved. Otherwise, the soft tissue and also bones are unremarkable. So, conclusion: this is cardiomegaly, giving the appearance likely features of pericardial effusions, with no evidence of pulmonary edema. The differential of the pericardial effusions include valvular heart disease such as mitral stenosis, cardiomyopathy, congenital such as Epstein anomaly, as well as congenital cardiac failure. I would like to correlate with the echo finding.
Okay, fine. So diagnosis part, you're okay, you did all right. So this is a typical appearance of a pericardial effusion. Okay, so after you say that is a pericardial effusion, your next sentence would be you would like to do an echocardiogram to confirm the diagnosis. All right. So then what happens is most times the exam, you sort of have a tendency to give a differential diagnosis which does not fit the image. Okay. So I agree with you, all the differential diagnosis you gave are causes of a grossly enlarged heart. Yes, but it does not fit in this particular case. So don't do that in the exam, not in this case or even in other cases, If there is a spot diagnosis, it cannot be anything else. And valvular heart disease doesn't appear like this, all right? Cardiomyopathy, possible, but doesn't give a globular shaped heart. Cardiomyopathies and valvular heart disease usually will have pulmonary congestion. So the vessels all become enlarged, all right? And Epstein anomaly is not like this, all right? And what's the other one you gave? Okay, and a congestive heart failure, okay?
Yeah.
This is also not like this. Because you see, if you look at for such a big heart, something is not right. Why you can hardly see the vessels? Why is that? What's happening? Huh? Why is it that you can hardly see the vessels?
Because can you repeat the question, Prof?
Pardon? No, why is it that you can hardly see the vessels?
I'm not sure.
Not sure.
Not sure.
Exposure.
Something has happened here. Never mind. Not sure. Why is that? Because
Maybe the
how's the cardiac output in this particular case?
reduce output.
Yeah. Yeah. Okay. So no blood can come out of the heart. No blood goes into the pulmonary arteries, and not much blood goes into. So because of that, not much blood in the veins as well, right? So
See.
that's why for such a big heart, the lungs, like, there's no evidence of failure.
Understood.
Yeah. So these are all the things that can happen. Is a dynamic thing that will explain a lot of things on the radiograph. Okay. So remember two things. The moment you think the diagnosis is something, you would ask for some other test to confirm your diagnosis, like in this case, an echo. And then if there's if there's a differential diagnosis for this, but does not fit the image, don't mention it. All right.
Okay, sure. Thank you.
Okay, next.
I'm Chan from UM. I would like to review this chest radiograph for a skeletal mature patient. Okay, from both lung fields, there's no consolidation, cavitation, or lung nodule. No pneumothorax. The both high, there's a triangular opacity on the right lower zone, which obscuring the right heart, right hemidiaphragm. So it's suggestive of right lower lobe collapse. Otherwise, no purification surrounding both hilar unremarkable. No soft tissue, bones are also unremarkable. Trachea is midline. So this is a case of right lower lobe collapse. We like to suggest CCT thorax to look for the cause, maybe bronchogenic carcinoma.
And what do you think the patient will benefit from besides that?
And also cause and then collapse.
So
And
what do you think the clinician will do?
bronchoscopic biopsy.
Yes. Yeah, okay. So the patient will benefit from a CT, contrast enhanced CT of the chest and bronchoscopy. Okay. So CT enhanced the chest, we see a mass lesion, then need a bronchoscopy to get the biopsy. Right? Okay. So this is a typical lower lobe collapse. Okay, remember I was telling you about silhouette sign. Okay. So you see the diaphragm and then it stops there. Because after this, there's no air over the diaphragm because the collapsed lung has come in and sitting over the diaphragm. So there's no air near the diaphragm to see the diaphragmatic surface. So that's silhouette sign. Okay. Then there are other clues. The transverse fissure is depressed. Okay. That's number one. Increased lucency in the lower zone. Number two, the lower lobe bronchus you can't see. See here, see the lower lobe bronchus? Lower lobe bronchus is buried inside the collapse. Okay, so there are other features besides the triangular opacity, right? So this is one collapse. So there should be another four more coming along the way. So remember, why is so important not to miss collapses?
Don't want to. One of the causes of collapse can be malignancy, which we don't want to miss.
Yeah, so the patient will present with a cough for 3 months or something like that, in a smoker, and then you do a chest X-ray. One look at this, you may just ignore the collapse, the triangular opacity, okay? Because you have to think about it. You have to think, is there a collapse or not? And then look. Otherwise, you will just brush through it and then not make the diagnosis. Because next time he comes in, because now no metastasis. Then you wait for another 6 months and he comes in, then you have metastasis, then that's not very good for him. Okay?
Okay. Thank you, Dato.
Okay. So see. Okay, come somebody do.
Good evening, Izudin from IUM. So this is the lumbosacral radiograph in AP and lateral projection. So in the NP view, I can see there is you see that there is abnormal widening of the increase in the interpeduncular distance with narrowing of the pedicles. We cannot appreciate any focal lytic or sclerotic bone lesion. No soft tissue mass, bilateral psoas shadows are preserved. On the lateral projection, I cannot appreciate any significant scalloping of the posterior vertebral body. However, I can see there is there might be there is scalloping of the anterior vertebral body at L2 and L3. So my provisional diagnosis would be centered around causes of widened interpedicular distance, which include presence of intraspinal mass, such as nerve sheath tumor or intramedullary mass, ependymoma, meningioma, schwannoma, or it could also be due to
Okay, so if you say those, if you
Could
say
be.
it's due to masses, then it has to be one, right? Why is this one is huge, this one is huge, this one is huge? So it's multiple areas. So you can't have. So you're trying to say that there's a schwannoma there, there's another one there, there's another one there, like that, is it? Cannot be, right?
Yes,
So why
yes.
is the whole canal widened? What does it call? What do you call that?
It's ectasia of the dura, dural ectasia.
Yes, now you start talking. What's the causes of dural ectasia?
Could be like in certain syndromes, such as in Marfan syndrome.
Yes.
ED syndrome can also cause this, Ehlers-Danlos.
Yes, okay. So these are the causes. These are soft tissue problems. You know, the connective tissues become soft and weak. That's why they get these issues. Okay. So now, between Ehlers-Danlos and Marfan's, which do you think this is? You mentioned something about scalloping of the anterior margin. Why is this happening?
Could be neurofibromatosis.
No, I was telling between Ehlers-Danlos and Marfan's. Which do you think this is? If you see scalloping of the anterior vertebral body, what can that be due to?
This could be in Marfan syndrome. There's also aortic aneurysm.
So you can get aneurysm not in the aorta, you can get in other vessels as well because the connective tissue is weak. The medial wall the media is weak of the wall, you see, so it dilates. So you get inducible dilatation. So your next sentence you say is you want to do what?
I would to further assess with CT angiography abdomen.
Yeah, the CT angiogram of the aorta. Okay. So what physical sign they may have?
Orphan, tall,
Okay, and in the aorta, what can they find?
sorry,
What will they find in the aorta?
aorta usually we can find a dilatation of the aortic root.
Yes, and therefore they will
Ascending
get,
aorta,
and when they get dilatation of the aortic root, they will get what?
coronary artery dissection.
So you get aortic regurgitation,
Aortic dissection.
aortic regurgitation. Okay.
Regurgitation. Okay.
Yeah. Okay. All right. So the MCQ will say aortic regurgitation can be a feature of Marfan. Is it true or false? No, like that. So you need to know, right? Yes. Okay, so this is a case of dural ectasia. So there are many causes. Then you start thinking, what are the possibilities here? Okay. See, this is how the exam is. They want to discuss. They want to make you think. Possibilities and come to something. Okay. Okay. Next.
Hi, Datuk. I'm Diana from UM. I would like to try.
Speak. Be it louder. I can't hear you so well.
So this is a frontal abdominal radiograph of an adult patient. There is I can see there is a lucency around the liver with lucency outlining the liver margin as well as at the paravertebral region along the psoas muscle, the right psoas as well.
Yes.
Um,
So what is causing that lucency?
retroperitoneal air.
Yes. Okay. So this is the case of retroperitoneal air, right, on the right side. Okay. Now you want to start thinking, what are the possible causes of retroperitoneal air?
Because of trauma.
Okay. No history of trauma. Yes. Rare, but no history of trauma. Yes.
It could come from retroperitoneal organs. Probably from the it could be some emphysematous infection of the retroperitoneal organs.
Yes. Okay.
Or a part of the duodenum that is at the retroperitoneal region.
Yes. Okay. So some infection, the retroperitoneal organs, like even bad emphysematous Pyelonephritis can get air in the retroperitoneal space. Okay, yes. So infections. Then you say something like what organ? The duodenum.
Yes, the
What about the duodenum?
perforation.
Perforation, yes. Perforation of a viscous. Okay. Now I'm going to ask you anatomy. So what are the possible viscous that can perforate and end up with air in the retroperitoneum? You mentioned duodenum. Which part of duodenum?
D2, second
And
part of the duodenum.
D2.
And D3, D2 and D3.
Yes, D2 and D3. Okay, from D1, it goes, then when it goes to D2, it goes retroperitoneum. Then from D3, when it goes to D4, it comes out. Okay, so D2 and D3. Okay, where else? Retroperitoneum, where else?
Descending, also the descending colon.
Pardon?
The ascending and also the descending colon is also a retroperitoneum.
Ascending and descending colon. Yes, you're right.
The esophagus also is at the is also retroperitoneum.
Yeah, but it won't go to retroperitoneum. Retroperitoneum is the abdomen, right?
Yeah.
Okay. So esophagus perforation is in the mediastinum, right?
Yeah. Rectum.
Yes, okay, yes, in the rectum, okay. So in this particular case, which do you think it is? The clue is there on the radiograph.
Face it only involve the right side. So I think it's probably the D2 part of the duodenum.
So you think it's from the duodenum, okay? You are right from the duodenum, but how did it happen and why did it happen? Again, there's a clue on the radiograph.
And see there is there is I think there is irregularity of the wall of the bowel wall as well as the
Oh, okay. Have a look at the liver. What do you see on the liver?
Mhm. Mhm. Mm,
What do you see on the liver?
see there is some opacity like linear branching opacity
Ah,
going
yes.
at the liver.
So what is that?
Or likely a previous procedure.
Yes, like what?
ERCP.
Yes, ERCP. Yes, because there's contrast in the biliary system. So
Yeah.
now you can tie two together. How did you get air in the retroperitoneum?
It is second part of the duodenum perforation likely secondary to the ERCP.
Yes, and when does it happen? When they do the endoscopy and they go to the second part, how do they perforate usually? Because of what?
Sphincterotomy of the
Yes, when they do the sphincterotomy, yes, because they will cut posteriorly, right? They won't cut anteriorly, so they can get perforation, and this is what you will see. So if you end up reporting a post ERCP radiograph, this is something you look for, right? What's the treatment for this usually?
maybe they would go, I mean they would do scope and do repair. They would
No, usually it's conservative because it's just a small cut, and usually when they do the cut, they will actually detect it early. They will know that they're perforated and they just stop. And then they just nail only the mouth, the patient. So no feeding through the mouth, and then the thing usually heals. Right? That's the usual thing that happens. But of course, there's a risk of infection and things like that. But most times it's conservative. Okay. So in the exam, they will ask you even anatomy. So it's important to know the structures that are retroperitoneal, because say the patient comes in with an acute abdomen and you do a CT from emergency department and you see only retroperitoneal air, you don't see intraperitoneal air. All right. So then you want to start thinking, okay, so this air must have come from structures that are retroperitoneal. Then you look at the rectum. Maybe there's a diverticulum close to the rectum near the sigmoid that perforated, or diverticulum, the ascending or descending colon that perforated into the posterior peritoneum, right? So, and you look also around the duodenum. Maybe it's a perforated ulcer. So this is how it's so important to know the anatomy and what are the retroperitoneal structures when you see air in the retroperitoneum. Okay.
Okay, thank you, Doctor.
Okay, next.
Isaac from UIA. So I'm given a frontal chest radiograph in skeletal masturbation. From this chest radiograph, I can see there is a multiple reticular opacities seen involving both lung fields, and there is several lung nodules with the largest seen at the bilateral lower zone as well. Apart from that, I don't see any consolidation, no cavitating lesion. There is no pleural effusion noted bilaterally, and there is no pneumothorax. I don't see any hilar leaf adenopathy or widening of mediastinum. The heart is not enlarged. Normal cardiomediastinal contours can still preserve. Apart from that, I see there is a slightly tracheal deviation to the left side. Otherwise, I don't see any apparent soft tissue swelling in the neck. There is no the visualized bones unremarkable. I don't see any erosion. So I would like to conclude this is a case of multiple reticular nodular opacity involving bilateral lungs. So this could be because of the tracheal deviation. I'm thinking first, my professional diagnosis is it could be thyroid carcinoma with mets to the lung. And next, I would like to perform a CT CT for staging.
Okay, fine. So you saw these lesions in the lungs. Why do you use the word reticular? Why? What does reticular mean?
The lines.
Yes. Okay. Now you also said that this is likely metastasis from the thyroid, right? And why do you say it's metastasis? Because it's more in the lower zones and it's larger in the lower zones. Okay. So it's like a raindrop, small at the top and then gets larger and larger and more at the bottom. Right? So that's fairly typical of metastasis. And these metastases are nodules. They don't present as reticular opacities. Reticular opacity is interstitial lung disease. So sometimes there's a tendency to link the two words together. Everything is reticular nodular. It can either be nodular or reticular or both. Okay. In this particular case, there are multiple small nodules. Okay. For the lungs, more in the lower zones and larger in the lower zones. So it's typical of raindrop appearance. Raindrop appearance usually means it's metastasis. And what are the common places that you get metastasis like this from? Okay, thyroid is one. What else?
RCC from renal,
Yes. Yes, someone.
melanoma,
Yes, not so common. Yes. Someone
uh,
common one is where?
breast
Yes,
carcinoma.
breast. Yeah, breast carcinoma or even lung carcinoma. So these are the common places, all right? But thyroid and RCC would be the top two. And then you notice the deviation. So likely there's a mass in the right lobe of thyroid. You do a CT, is it? Okay, you can do a CT to look. What else would be more useful?
Ultrasound to look.
Yes. Then you can say, I'd like to do an ultrasound of the thyroid. And if there's a mass, we can do a final aspiration and confirm the diagnosis. Okay. So again, this is a viva. You are not a radiologist just sitting in the room making a report. You're going to be part of the team managing the patient. So you must say all these things. Okay.
Okay,
I keep repeating this. You all are now clinical radiologists, not the radiologist sitting in the room just reporting. All right. Remember that. Okay, somebody shout out diagnosis. Just say, what is this?
Freiberg disease.
Yeah, Freiberg disease. So how do you describe this?
Flattening and sclerosis of the
Yes,
second
flattening and
metatarsus.
sclerosis. Anywhere you get flattening and sclerosis over a joint surface, it is the pathology or the pathology that's happening is a avascular necrosis. All right, and a lot of places in the body will have this, and they all have a name. So for the exam purpose, you need to know all the names. All right. The many areas, just go and read what are the possible places they can ask you. Okay, next.
Okay, Magat from UM. Okay, this is a chest radiograph of an adult in frontal position. I can see that the heart is enlarged, and also I can see there's opacity seen at the both mid zones, reticular opacity, and there's also evidence of curly B line at the periphery of the right lower zone and left lower zone. Otherwise, I don't see any lung nodules or cavitation. I also like to review the review areas. Both apex looks okay. No highland nodes. No pleural effusion bilaterally. The rest of the bone is unremarkable. No evidence of fracture or mass. So this may represent cardiomegaly with pulmonary edema. I would like to do an echocardiogram to confirm my finding and correlate with a patient presentation.
Okay, fine. So this is right. So this is a case of pulmonary edema, but it's early pulmonary edema, more interstitial stage. So good, you recognize the curly B lines. Curly B lines in the exam purpose, two things you think of. If the heart is big, it's heart failure. If the heart is not big, what do you think of?
Maybe for in case of malignancy such as lymphangiomatosis carcinomatosis.
Yes, lymphangitis carcinomatosa. Okay, so these are the two diagnoses you think about when you see curly B lines. All right, so heart is not very big, but big, and then you see this upper lobe venous diversion. You see this haziness like airspace opacity. So all these points towards, and just do an echo, and you get the diagnosis. What blood test usually they will do?
Uh, Pro BNP.
Yeah, okay. See this. So sometimes they'll ask you this thing because they want to know you are a clinical radiologist or not. Okay, so they may do a chest X-ray and they'll say raised pro BNP, you know, and then do a chest X-ray, so you know what you're looking for, right? Okay, next. Okay, come.
Hi, no daripada UAE. Presented to me is the selected radiograph image of lower face in anterior posterior position of skeletally adult patient, skeletally matched patient. I can see there is a well-defined lucent lesion seen at the left mandibular region. It has sclerotic border with multiple internal septation within. I can see adjacent to it, there is a a teeth, but otherwise,
Yes, okay, go on.
otherwise I cannot appreciate any obvious periosteal reaction. The rest of the bone seems to be preserved with no evidence of fracture. There is no soft tissue component. The visualized maxillary sinus also preserved with no evidence of air fluid level. I also cannot appreciate any impacted teeth in this radiograph. So for this diagnosis, I'm giving diagnosis of ameloblastoma. And the other differential diagnosis is odontogenic keratosis and also aneurysmal bone cyst.
Okay, fine. So what do you call this? What's the name you
Is
give
it
it?
odontoma?
No. Well, why is the teeth up there, not down here? What is it doing?
Floating teeth.
Yes, okay. So in this case, you can think of two broad things. One is expansile bony lesion. Okay. Anywhere in the body, expansile bony lesion, there's a differential diagnosis. And in particular case in the mandible, you can narrow it down. Okay, number one. Number two, you can also talk about the differential diagnosis of floating teeth. What causes floating teeth? So then again, you get a set of differential diagnosis. Then if you merge the two, you'll get a subset of a few differential diagnoses, and those will be the ones you'll talk about. Okay. Well, metastasis and myeloma will always fall in this category, all right? Although this looks fairly benign, but expansile lytic lesion, this too comes to mind as well, all right? So you are right, this is ameloblastoma because it's in the mandible and it gives a floating teeth appearance. Okay, so why do you say how else the imaging, what else you would do? Why didn't say that?
CT scan, Dato.
CT scan? You think so? A CT scan?
CBC, is it CBCT?
Okay, you can do a CT, but MR would be good actually, because you say it's aneurysmal bone cyst is a differential diagnosis, right?
Yes.
Yeah, so MR is excellent, see?
Okay.
Okay, I think we'll stop here. Quite a number of interesting cases, like things that may come on the exam and how the discussion will go along. So remember, you all are now becoming clinical radiologists. Don't stop at the film. Remember, there's a patient there. There's a team of doctors managing the patient. Go beyond the film. Many a time, getting the diagnosis is one part, but going beyond the film and discussing is another part. Okay. So once, if you do, that means the examiner is happy, you know. So this patient is this doctor is ready to go out there and serve the patient and make the reports on their own. All right, that's what we look for. Okay, then good luck. So you got to three more weeks. So now's the time to peek, see more pictures until it comes a time where once you see a picture, you say, okay, I've seen this before. You know, that's how it should be. So you must have seen enough. Okay, then see you all next week.
Thank you, Dato'.
Thank you, Dato'.
Thank you,
Thank
Dato'.
you.
Thank you, Dato'.
Uh,